All right, so this is the part 3 video for chapter 15. So we had just finished talking about PTSD, and now we're going to shift gears and talk about obsessive compulsive disorder, or OCD. Now, this chapter in the DSM includes several different disorders as OCD disorders, but we're going to focus on just OCD. So OCD is recurrent, persistent, unwanted thoughts, which are called obsessions, and images and repetitive ritualized behaviors or mental acts, which are called compulsions. And the person typically engages in the compulsions as a way to control or reduce the impact of the obsession. So it's essentially a coping strategy. It's just highly problematic. Now, similar to some of the other disorders we've talked about, many of us have some symptoms of OCD. Like, I know that I'm kind of a generally anxious person. I like to double check things. I want to double check that I turn the coffee pot off, that I lock the door, make sure that I fed the cat. But OCD is more than just that kind of like double checking behavior that a lot of us do, in the sense that it's very time consuming. And that's one of the main symptoms and main questions that I'm going to ask people about when I see them in a clinical setting is, how much time do you spend engaging in your compulsions? Lots of different things have been linked as risk factors to OCD. One of the biggest ones being abnormalities in the prefrontal cortex. Because again, you can think of the prefrontal cortex as kind of the brake that tries to stop some of our anxiety by using reason to remind ourselves you already double checked the coffee pot's off. Whereas people with OCD don't really have that kind of, again, like cognitive brake because of abnormalities in the prefrontal cortex. They also tend to ruminate, meaning they get kind of stuck on that obsession. They can't get themselves off of it. And then also behavioral rigidity, meaning, again, they kind of form these routines and ritualized behaviors very quickly. So next, your textbook talks about personality disorders. The key word here in the definition is pervasive. Personality disorders are extremely pervasive and long-lasting patterns of thoughts and feelings. And these thoughts and feelings are going to cause great distress in people and also in relationships. And so these are lifelong. These typically present around age 16, 17, and are there in all situations, in all relationships. And so what's interesting about personality disorders is they can impact the relationship between the client and the therapist in ways other disorders don't. And so when you ask clinicians what disorders tend to be the most difficult to work with, they tend to say people with personality disorders for that very reason. So in DSM-5, there are 12 different disorders. Your textbook highlights borderline and antisocial just because those are more commonly talked about. They tend to be portrayed in movies and TV shows because they can be dramatized and create very interesting characters in extreme situations. But there certainly are other disorders that the textbook doesn't highlight that can also impact people's behaviors and their relationships. So again, the textbook just chose to focus on those two, but there are several others in the DSM-5. Your textbook also talks about addictions or addictive disorders. The DSM-5 talks about 10 classes of drugs, which can include things like alcohol, hallucinogens, inhalants. There's lots of different drugs that are kind of broken down and talked about in the DSM-5. And again, it's that interesting question of what's typical and what's atypical in terms of drug use. If somebody that binge drinks when they're in college, is that considered alcohol abuse, or is that just kind of typical college activity? What's a social drinker versus someone who's actually an alcoholic? So there are some kind of blurred lines and some difficult decisions that have to be made when you're working with patients that are abusing particular drugs. It's also really hard to get a sense of how much people are using because people tend to downplay and also misunderstand quantities. So you might ask someone, how often do you drink and how much do you drink? And they might say, well, I have a glass of wine, after dinner once in a while. Well, if you were to actually sit in their house and watch them, you would actually find that their glass of wine is one of those glasses that holds an entire bottle. And their once in a while after dinner is every day, all day, right? So depending on the relationship the patient has with the therapist, they might be more or less honest. But it isn't always about honesty. It isn't always that they're misleading. They just might genuinely misunderstand. Most people underestimate the amount of particularly alcohol, but really any drug that they're consuming. Like if you asked me how much coffee I drink each day, I would say a cup of coffee. Well, if you ask my wife, she's going to be able to tell you I actually probably, based on ounces, consume more like 3 cups. But I have one of those giant mugs, and before it's even completely empty, I'm refilling it. So I don't really have a honest and accurate sense of how much I'm consuming. So there's lots of different risk factors that might increase risk for addictive disorders. There certainly are biological predispositions. So, for example, we know that alcoholism runs in families. And so some of that is biological, meaning that we see differences in things like activity of neurotransmitters, for example. We also know that cultural influences matter. In cultures where young children are encouraged to drink wine, for example, and are educated and reinforced in healthy and safe drinking behaviors, we see that we don't have as high levels of addictive disorders, where in places like the United States, where it's frowned upon and there's so many rules and regulations, and people aren't allowed to drink until they're 21, we see higher levels of addictive disorders because we don't start those behaviors young in a safe family context where we're provided information on how to do it safely. So it's kind of this combined influence of biological predispositions and cultural influences. Your textbook also talks about dissociative identity disorder. I kind of laughed when I saw that they included it, just because this is not a very commonly diagnosed disorder, and it is an area of huge controversy. So the reason your textbook talks about the mood disorders and anxiety, PTSD, substance uses, those are very common disorders. Okay, so I can tell you, if you go into the field of clinical psychology, 75% of your patients will have one of those disorders. Personality disorders are much more uncommon. I can tell you in 5 years of clinical practice, I maybe saw a handful of patients with personality disorders, where all day, every day, I was working with patients with depression and anxiety. The reason the textbook talks about personality disorders is because we often see it in TV shows and movies, and so your textbook wanted to provide some more scholarly information about it. Dissociative identity disorder, I think your textbook included because it's interesting, and there is a lot of controversy, so this was a little bit more of a wow factor, I think, from your textbook. So please do not think that DID, or dissociative identity disorder, is common. It is not. It is also probably the most controversial disorder in the entire DSM. So this used to be called multiple personality disorder. So chances are you have heard of this. You just probably haven't heard of it as DID. So essentially it's where the person has more than one distinct personality. That distinct personality is going to have a different name. It could be a different age than their true personality. It might have, that personality might have different skills, different abilities, different interests, different everything. And so it's often portrayed in movies as this person who shifts between different personalities, without any awareness. The personalities have different memories. Now, in actuality, that is what DID is. Okay, that's accurate. The question, though, is what are we actually capturing in the term DID? Because essentially, the way that the disorder was initially conceptualized and initially talked about was it was a person who experienced very extreme and serious trauma as a child, so something like child abuse, sexual abuse, and their personality fractured into different personalities as a way to cope, right? To kind of create some distance between themselves and what happened to them. That has pretty serious criticism in terms of there isn't a ton of empirical support. Okay. In actuality, what we think as a field is that DID is what we call a culture-bound syndrome. Essentially, it's a socio-cognitive explanation where the person, they probably experienced trauma. That's pretty agreed upon, is that people that have DID probably experienced intense trauma, and experienced difficulties as a result, which isn't surprising. But what happens is that a few therapists in the country think that DID is a legitimate disorder. And so they help the person come to understand themselves by identifying distinct personalities. And so there seems to be this kind of emerging understanding as a field that these individuals don't have distinct personalities before they enter therapy. It's the therapist that helps them conceptualize themselves in that way. So I want to, kind of highlight and kind of pause here. DID seems to be a label used in the context of people that experience extreme trauma that seek help, and a therapist helps them conceptualize it this way. So these are not people that are lying. Okay, that is not what I'm trying to say here. These are individuals that, through a process with a therapist, have come to understand themselves by identifying distinct personalities. Do they actually have distinct personalities is the question. That's what lacks empirical support. So that's why this is such a highly kind of contested and controversial disorder in the field of clinical psychology, is we don't really know what this disorder represents. Does it represent truly distinct personalities? Or does it just simply represent the way someone has come to conceptualize themselves in a way that helps them feel better and function better in their everyday life? Okay, so essentially we don't know. This disorder is very rarely diagnosed. Okay, so I've never seen a patient in real life with this disorder. I have never known a therapist in real life that treated someone with this disorder. But there are therapists out there that use this diagnostic label, and there are people out there that are diagnosed with this disorder. You might know someone. You might be one of those people. And so this isn't to question, the individuals that present for therapy and are diagnosed with DID. This is to bring into question, how can the field better understand this symptom presentation and better support these individuals? Because again, these are typically people that have experienced pretty extreme trauma. All right, and then the last disorder category your textbook talks about is schizophrenia, which is a type of psychosis. So essentially it's where somebody has distorted perceptions of reality. They might have irrational behavior. The key here again being an inability to function. The DSM includes several different disorders in the chapter on schizophrenia, and these disorders vary in severity and duration. But generally speaking, these are disorders where someone has hallucinations, maybe they see things that aren't there, have delusions, like believing things even though the evidence contradicts it. They might have disorganized thoughts, words, behaviors. They might have flat affect. There's lots of different ways that this can present. But again, the classic kind of being that delusion and hallucination combination. This typically onsets around late adolescence, early adulthood, so age, I'd say 17 to 21 is kind of the classic time it comes on. And mostly the field has focused on biological explanations. But I can tell you there's some controversy there too. I mean, surprise, surprise, there's controversy everywhere. But some people have questioned whether the biological things we see associated with schizophrenia, are they the consequence of medications or are they causes of schizophrenia? Because we typically cannot learn about people's brains and study their brains until after they're deceased. And if it's someone with schizophrenia, chances are they've been treated with antipsychotics for most of their life. And so there is this question in the field, how much of what we see going on in people's brains that have schizophrenia are a consequence of antipsychotic medications versus causes of the disorder itself, which I just think is a fascinating question and certainly something that future researchers could look into. So that brings me to the end of chapter 15. Again, that was just a quick trip through the field of clinical psychology and some of the more commonly diagnosed disorders and some of the just more kind of interesting controversial disorders all blended together. Please let me know if you have any questions. I'm happy to chat about psychological disorders. Again, it's one of my main areas of expertise and interest, and I hope everyone's doing well.